Every time you scan an incompetent great saphenous vein, you face a choice. Do you ablate the vein to resolve the patient's venous reflux, or do you leave it intact in case they need a coronary artery bypass graft down the line? Making that call depends heavily on the size of the vein. But looking at the exact same vein, two different clinicians can record completely different diameters. The difference comes down entirely to how the patient is positioned during the ultrasound. When assessing for venous ablation, guidelines require a standing position. Gravity forces blood downward, maximally dilating the vein. Preoperative mapping for bypass uses a supine position. Without gravity driving blood down, the vein naturally decompresses and shrinks. Taking a standing measurement and checking it against supine surgical criteria creates a mismatch in the data. To know if a vein is actually suitable for bypass, we have to calculate how it behaves across different states. Moving a patient from a standing to a supine position triggers what we call postural diameter change. Simply having the patient lie flat decreases the GSV diameter by roughly 19 to 24%. But the size of the vein in the supine position isn't its final size on the operating table. The administration of anesthesia and the physical process of endoscopic harvesting trigger the vessel to dilate. By the time the surgical preparation and mechanical distension are complete, that previously shrunken supine vein expands by an average of 47%. Let's test this conversion. If you measure a patient's standing GSV and it comes out to exactly 4.0 millimeters, will it fall into the ideal 3 to 6 millimeter range required for a bypass conduit? First, lying supine, that 4.0 millimeter vein loses 20% of its volume, shrinking to 3.2 millimeters. Factoring in harvest expansion, that 3.2 millimeter vessel dilates by 47%, yielding a final surgical diameter of 4.7 millimeters, perfectly centered in the ideal bypass range. Veins that measure small during a routine standing ultrasound often translate into perfectly sized conduits once they reach the operating room. This chart shows the proportion of varicose veins that are structurally viable for surgery. Over 82.6% of varicose-grade saphenous veins were physically unusable as bypass conduits from the start, regardless of their overall diameter. A successful graft depends entirely on the quality of the vessel wall. A thick, diseased wall is an independent and highly accurate predictor of early graft failure. There are strict thresholds for this. If the tunica media measures thicker than 257 micrometers, or the total wall thickness exceeds 437 micrometers, the vein is sclerotic. Even if it can be successfully harvested, it is highly likely to occlude shortly after grafting. Other morphological defects like calcifications or luminal irregularities and tortuosity greater than 6 millimeters also completely disqualify the vein from being used as a bypass conduit. You do not need to hesitate when treating heavily diseased, thick-walled varicose veins. They hold no salvage value for cardiac surgery, making them clear candidates for ablation. For patients with a high risk of coronary artery disease, reserve your preservation efforts for veins that show mild C2 disease, possess smooth, thin walls, and measure under 5 millimeters in the standing position. If a patient meets these exact preservation criteria but still has symptoms requiring treatment, you can use vein-sparing techniques to resolve localized issues without destroying the main trunk. In cases with segmental reflux but a competent saphenofemoral junction, targeted techniques like branch phlebectomy or the Chiva method can eliminate the symptoms. The main trunk stays perfectly intact for future bypass needs. This decision matrix outlines the rules. You ablate when the wall is thick, calcified, or measures over 7 millimeters standing. You preserve when the wall is thin, smooth, and measures under 5 millimeters standing. Always evaluate bypass suitability based on supine behavior. Always assess for ablation in the standing position, and prioritize the integrity of the vessel wall over sheer diameter.